Okay, now we're going to talk about hematologic problems. And this will be a short video of the first portion of this. We're going to do three videos, three narrated presentations for you. So this is the first one, hematologic. Anemia is widely seen, and it is the deficiency in the number of our red cells, hemoglobin, and hematocrit, and that's what anemia is. It's decreasing those three indices. The causes: decreased red blood cell production, and this shows you what are those reasons, some of those reasons. Blood loss, so if there's acute bleeding, usually through the GI system, or could be because of trauma. And then increased RBC destruction, so if there's increased hemolysis, and some of those are sickle cell disease medications, and incompatible blood and trauma again. So those are causes. Yeah. The RBC function, you know that. This is just a review, so you review that. Anemia is not a specific disease, but it's based on your CBC. Now remember, in three classes ago, we looked at the CBC, what the components are, what are the norms, what do they mean. This is information you have to know as a nurse. The reticulocyte count and the peripheral blood smear, those are diagnostic procedures used to diagnose. We look at the cell characteristic, what's the size of the red blood cell and what is the color. And then we also look at the causing the anemia. Now, the skin will manifest signs of anemia: pallor. Students love pallor. Pallor is paleness. And a lot of times we can assess the anemia where? We look in the conjunctiva, and we know that that person is anemic because of the pallor of the conjunctiva. Jaundice is the serum increased concentration of bilirubin, and that's the yellowing of the skin. And then itching or pruritus, increased serum and skin bile salt concentrations. So those are all signs and manifestations. Fatigue, as the hemoglobin and hematocrit drop, the patient gets very tired and fatigued. Impaired nutritional status is, we'll see some of the anemias are caused by impaired nutrition. And then ineffective tissue perfusion, that's one of the nursing diagnoses, the NANDAs. Nursing care varies based on the cause and the specific needs. So we see patients with fatigue, of course, you're going to rest, alternate forms of rest and activity. They do need to plan some activity because that generates energy. We're going to accommodate their energy levels and do things a little differently. Help to minimize their risk of injury from falls, and monitor their response, evaluate nutrition. Anemia is not normal in aging. It is not a normal process of aging. It's more common in the 70s and beyond, and a lot of that is related to nutrition or underlying causes. So sometimes they overlook in the elderly the anemia because of other health conditions and of normal aging. Decreased erythrocyte production. So the RBC production, which is erythropoiesis, has to be equal with the destruction. So the average life of a red blood cell is 120 days. So in those 120 days, at the end of that cycle, as this cell dies, there must be production of new red blood cells. And the kidneys really function in this because they produce the erythropoietin. So there should be a balance. Three changes that can decrease the RBC production is decreased hemoglobin synthesis, defective DNA synthesis, and diminished availability of erythrocyte precursors. So maybe the kidneys are not producing enough erythropoietin so that the body can produce red blood cells. Iron deficiency anemia is the most common nutritional disorder in the world. Happens to the very young, secondary to a poor diet, and women in their reproductive years. And let's think about that. Why would it be women in their reproductive years? What process do these women have going on? Inadequate dietary intake, especially if people are vegetarian or choose an alternate diet. They have to be very careful to make sure they get the iron that they need. We need more iron with women as women with menstruation and pregnancy. Malabsorptions. Iron gets absorbed in the duodenum. It's called the intrinsic factor. And sometimes diseases or surgery can alter that intrinsic factor, and it's not absorbed. So maybe we have an adequate intake, but it's not being absorbed. Blood loss. If we have acute blood loss, that can be a cause of iron deficiency anemia in adults. Chronic blood loss happens mostly through the GI and GU systems, and sometimes we don't pick it up in the GI system. If it's a high bleed and it's just a minimal bleed, look at what is that stool going to look like, what's going to be the color and consistency of that stool. And then in GU, a lot of times there's microscopic red blood cells in the urine, but we don't see it, but they can see it on a microscope when we get a urine sample. So it may take time to identify what's happening. Postmenopausal bleeding can be a cause. Chronic kidney disease, because like I said, the erythropoietin is produced in the kidneys, and dialysis may contribute also to anemia. So again, pallor is common, that paleness of the skin, and in the dark skin, brown and African American and brown people, you need to know where are you going to assess for pallor. You should have learned that in health assessment, so that's going to be a question for class. Glossitis, which is inflammation of the tongue, that's the second. And cheilitis, which is inflammation of the lips, is the third. So iron deficiency anemia, how do we diagnose it? That lab, that CBC, the CBC gives you the RBC, the WBC, the platelet counts. It gives you the hemoglobin, HGB, hematocrit, HCT, MCV, mean corpuscle volume, MCH, mean corpuscle hemoglobin, and MCHC, reticulocytes, serum iron. So what is the iron level? TIBC is the total iron binding capacity. So you may have a normal iron level, but the TIBC is low, which means that the iron is not going to bind and be absorbed where it needs to be. You want to look at the bilirubin and also the platelets. We do a stool for occult blood test. That's a guaiac of the stool or a hemocult. And you need to know how to do that. How do you prepare your patients? What will give you a false positive? What do you instruct the patient before they get a stool for occult blood? Endoscopy, which is the direct visualization with an endoscope, which is a scope with a light on it that goes down from the mouth down to the upper GI, it goes to the stomach. And then the colonoscopy is a direct visualization with a scope and a light on it from the bottom end, which goes into the rectum up through the colon. Again, you need to know how do you prepare your patients for these exams and what is your expectation, what would you need to pre and post, what would you need to notify the physician for. Are these procedures who require informed consent? And what type of assessment do you need prior to the procedure and post? And then the bone marrow biopsy. Our bone marrow is where our blood is made. So how do we prepare for a bone marrow biopsy? So does that, okay? Iron deficiency anemia, your interprofessional nursing management. There's a table in your book, 30-7, which talks about interprofessional care. So you want to pay close attention to that. And then how do we treat it? Drug therapy, oral iron. It's inexpensive and convenient. It's enteric coated or sustained release. The daily dose is 150 to 200 milligrams. Patients do complain about abdominal upset, stomach upset, nausea, pain, sometimes cramping, and we encourage them to take it at night if it bothers them. Best absorbed in an acidic environment, and best absorbed with which vitamin? What vitamin do we want to give with iron? I want you to answer that. Undiluted liquid iron can stain the teeth, so it should be diluted and drank through a straw. So what should we dilute it in? That's another question for you, for us to discuss in class. Side effects are heartburn, constipation, diarrhea. Constipation, very common. So a lot of times iron is given as a stool softener. Parenteral iron. Parenteral means IM or IV. It can be given either way. If it's going to be given IM, we need to give it via Z-track because it may stain the skin and it needs to go deep into the muscle to be absorbed. Again, we want to reassess this hemoglobin and hematocrit and your RBC count. So they need to get periodic blood tests. Emphasize their adherence to their diet and drug therapy. I want you to be able to write down and name 3 foods, common foods that are high in iron so that you can pick them out of a menu. And then we're going to monitor the liver for if they're on life iron therapy. Okay? So that concludes the beginning of this recorded session, the end of this recorded session.